Good afternoon, everyone, and we'd like to welcome you all here to our webinar from the Community Healthcare Cavan, Donegal, Leitrim, and Sligo, where we're talking about our falls prevention framework. So my name is Edel Brennan, and I'm the Clinical Coordinator for Falls and Bone Health. We have Colin McCann here, he's the Project Manager for the framework, and we also have Mary O'Donnell, and she's going to be doing her presentation today. Please note, before we get started, that this webinar is being recorded. All right, okay. So as I said, I'd just like to thank you all so much for logging on to this webinar. And I know a lot of you have actually logged on to our other webinars. So this is our 4th webinar. So we're getting through them and they've been really successful. So it's great to have that interest from everybody. So thank you. All right, so we're going to get started. So let's put everything into national context. We are an aging population. Our population of over 65 is going to double by 2051. In the latest report from the National Office of Clinical Audit, it showed that majority of 82% of major trauma in Ireland was due to low falls. So low falls is also known as a fall that occurs less than 2 meters from the ground. And 84% of these falls happen in the home or institution. So that's a nursing home where the person is living. So let's put this into local context. So we have 3 major acute hospitals in our area, Letterkenny, Sligo and Cavan. So between the years 2020 and 2023, there was an average of 3,347 falls related admissions to acute hospitals per year. This resulted in an average of 36,196 bed days per year. So, and then this resulted then the average length of stay was greater than 10 days. So it's a huge amount and it's a huge issue. So the above figures do not capture our unreported falls, injuries managed at GP level, that's, you know, your Colles fracture, your tibia fib, are those presenting to primary care, to your physiotherapist, occupational therapist, etc. It also doesn't cover those attendants at ED that do not require admission. Are the, the impact of falls related injuries on individuals, for example, in their workplace, family life, and care requirements. So we're heading for a falls related crisis in our health system, if we're not there already. So how is this project approaching this issue? Okay, well, 2 years ago, QSSI decided to produce a framework that acknowledges the multifactorial nature of falls and review best practice in relation to promote healthy aging, preventing falls, managing falls, and supporting people at risk post-fall. So the aim of our framework by the end of 2024, the Community Healthcare of Cavan, Donegal, Leitrim, Monaghan, Sligo will hope to have a framework that supports services across all care groups to reduce the number of harmful falls to our population here. So the framework is going to contain recommendations in relation to medication review, residential settings, incontinence, falls and technology, environmental issues, exercise and bone health. And these are our working groups. The framework will be informed by national and international best practice, including the World Fall Guidelines, which was launched September 2022, and the Australian Fall Guidelines, which is still in draft form and which is going to be launched this year. The framework will provide the basis for a falls prevention implementation plan. So this is our progress to date. So in the second quarter of 2022, okay, we formed these working groups, as I said, exercise and bone health, education, environment, medication review, residential and technology. So then the working groups all went and they looked at the most up-to-date research and, to come up with key findings and recommendations. And that had to be completed by the second quarter this year. So we're on target. So now where we are at the moment, okay, and this is where you come in. We're doing a period of review. We're getting feedback from you, experts in the area. And then after that, we're going to be drawing up the falls prevention framework, writing it up, looking at the introduction, the rationale, the background, the policy context, the need for integrated working, and as I said, the core elements of what we're going to be covering is promote healthy aging, preventing falls, managing falls, and supporting a person post-fall. And we hope to have that completed by the third quarter this year. Okay, so the purpose of these webinars is to seek feedback in relation to the work of our 4 working groups. As I said, this is our 4th and final webinar, so we're covering residential settings today. The remaining working groups focus on areas with limited emerging research, and that's incontinence and technology and falls. So it is important to note that the majority of the existing research relates to older adults. Expert opinion would indicate that much of this work is also applicable to people with intellectual and physical disabilities and complex enduring mental health issues. The work here is represented draws on previously international and national work, as I said, including the World Fall Guidelines, the Australian Fall Guidelines, still to be published, and the Affinity Project, which has been unpublished. Okay, so without further ado, I now am going to hand you over to Mary O'Donnell. She's the clinical nurse specialist in residential care facilities for older persons, Leighton, ICTOP, covering Sligo, Leitrim area. Okay, as I said, this webinar has been recorded. So I'm just going to set it up here. And I'm going to pass you over to Mary. My apologies. Sorry, here now.
I'll just take the opportunity to introduce myself, Adele. Colin McCann here, Projects Manager for Quality, Safety and Service Improvement. My apologies, folks, I'm having some technical issues this afternoon, so it's nice to finally join you, but I'm not sure how long I'll be here for. Great, Mary's ready to begin our presentation, so Mary, over to you.
Hello everybody, you're all very welcome to this webinar where I'm going to present the residential working group section of the Falls Prevention Framework, as Edel explained earlier. My name is Mary O'Donnell and I'm presenting on behalf of the rest of the residential working group, and I would like to acknowledge all my colleagues who have worked alongside for this project, and especially to Edel and Colin, who have supported and guided us to this point to date. So let's start with a brief introduction. The World Guidelines for Falls Prevention and Management have made key recommendations for the clinical implementation of fall prevention services and strategies in residential care facilities for older persons. While not all falls and injuries can be prevented, it is critical to have a systematic process of assessment, intervention, and monitoring to minimize falls risk. Because of the multiple intrinsic and extrinsic risk factors for falls in older persons in residential care facilities, we need multiple falls prevention interventions to reduce falls and improve the lives of older adults living in the residential care home settings. Key findings from the World Fall Guidelines include: in residential care facilities, all residents should be considered as high risk of falls, and a multifactorial falls risk assessment should be carried out on every resident. Falls account for 100% of all injury deaths that occur in care homes. Falls are at least 3 times more frequent in care homes than in community dwellings. 1 in 10 care home residents who fall sustain a fracture. And as you all would be aware, adverse consequences of falls for residents include reduced quality of life, increased fear of falling and restriction of activities, decreased ability to function, serious injuries, and increased risk of death. Anxiety among staff in residential care facilities, fear of litigation and complaints may have a negative impact on care staff willingness to encourage residents to be physically active. It's also important to note that 60 to 80% of residents are cognitively impaired. Improving food quality for older adults with adequate intakes of calcium and protein reduces falls and cost-effectively reduces fractures by potentially slowing the age-related increase in risk. Exercise programs to prevent falls in residential care should be encouraged for those willing and able. So the recommendations from the World Fall Guidelines include the following. First of all, the recommendation is that we do not use fall screening to identify residents at risk for falls. Instead, we recommend that all residents should be considered at high risk of falls. Screening tools that would have been used to date include the Canard and the FREDS. Also, physical restraints as a measure for falls prevention in residential care is not recommended. I suppose methods that might have been used in the past would include tables that would have been attached to Buxton chairs. Similarly, beds too low or too high are not recommended. So what is recommended? A multifactorial falls risk assessment should be performed at admission to identify factors contributing to falls risk, and appropriate interventions should be implemented to avoid falls and fall-related injuries in residents in long-term care. A targeted and individual plan of care should be developed based on the findings of the multifactorial falls risk assessment. A post-fall assessment following a fall is recommended in order to identify the mechanism of the fall, any resulting injuries, and any precipitating factors. Subsequent review and revision of the MFRAT or multifactorial falls risk assessment tool is recommended to adjust the intervention strategy for the individual and update the care plan, which is the falls care plan. Exercise programs in residential care should include moderate intensity strength and balance exercises tailored to the individual who are willing and able to participate. Success is higher when the programs are structured by a physiotherapist, supervised and adequately resourced. Support for continued exercise programs is recommended as the effect of structured exercise programs diminishes over time once the program has ended. Dietitians should assist with menu design to ensure adequate provision of dairy foods that reflect older persons' preferences. This may involve at least 3 servings of dairy foods to meet protein and calcium requirements each day. Vitamin D supplementation is also recommended for all older people in residential care. Recently, the Department of Health has made recommendations on dietary vitamin D. And for adults over 65, the recommendation is that each resident should have 15 micrograms or 600 units orally per day. The prescription of bone treatments is also important for older people with diagnosed osteoporosis and a history of low trauma fractures. Hip protection with the use of hip protectors should be considered to reduce the risk of falls-related fractures. But of course, we all know that this has to be done in consultation with the older person and each individual. So, having looked at all of the recommendations, we then examined what documentation would support the implementation of these recommendations. So, a standardized multifactorial falls risk assessment tool, or MFRAT, is needed to initiate individual care plan involving the resident, their nominated persons and staff. A standardized post-fall protocol is also recommended across all residential units. And we hope that the use of a standardized post-fall review log across all residential units will also be beneficial. Okay, so within our group, we considered and we looked at a number of different multifactorial falls risk assessment tools, including the assessment tool from CHO1, a recently reviewed comprehensive assessment tool from Community Healthcare East, and we also looked one in use in Scotland, not called an MFRAP, but called a Guide to Action, but the content being the same. So we basically compared all of these to make sure that in any example that we would show or use, that we would include all the risk factors that that could possibly exist for an older person of falls within the residential care setting. This brought us to look at a work undertaken by the National Quality Patient Safety Directorate, and which they had one which we quite liked, in that we could, it gave all of the risk factors, and we have amended that to include all of the risk factors, but we liked the way it was presented. And I have it up here now on the slide, just the first, it's a 3-page document. And as you can see, I'll just flick through it. It includes all the risk factors and it divides them into different categories. As you can see on the left-hand side of this, or my left-hand side, there's medication, cardiovascular, exercise, dietary, personal safety, and environmental safety categories for risk factors. And going back up to the beginning then it shows the active problems related to each of the different risk factors and prompts the person or the user, the staff using the document, towards interventions required for each of the problems identified with that risk factor. So we would hope that this could be tested and feedback given to us. And I suppose the more it's used, the better we'll find out how effective it can be for staff in residential care. So within this, when it's completed, all of the risk factors for each individual will be identified and on a particular date and time. The risk factors are then used to develop a falls care plan. Both of those documents, both the MFRAT and the falls care plan, are live documents which need to be reviewed. For example, when a person would have a further fall, become acutely ill, or for example, when a person attends hospital and returns to the nursing home, when there are potentially new risk factors. So I think it's important to emphasize that this is a live document which is continuously being reviewed. We next move on to an example of a post-fall protocol and post-fall log. And this document has been amended from original work undertaken by CH East. Here we'll see an example of a post-fall protocol. Again, it guides staff in the nursing home towards a flow chart of what needs to be done if somebody has fallen and what to do. So it gives guidance on what nursing assessments are required. And then once it has been identified whether a person has had no apparent injury, a minor injury, or a serious injury, it guides you to what actions need to be taken and what steps are needed following that incident. The next document is the post-fall review log. And again, within the World Fall Guidelines, it is recommended that a review of each fall is carried out to understand the circumstances of the fall for the individual and to identify any precipitating factors or possibly any new potential risks, where again, staff would work together to amend the multifactorial falls risk assessment and to continue to revise the falls care plan based on the new amended multifactorial falls risk assessment. So these are the references that we would have used, and as Edel would have said, we used the World Fall Guidelines 2022, NICE guidelines, and the draft guidelines of Australia and New Zealand to inform the evidence that we have provided today. And falls aren't an inevitable part of ageing, and it is the responsibility of all of us to ensure that we use the most up-to-date best practice in relation to preventing or reducing falls to the minimum and to reduce harm from falls for all our residents working in residential care facilities. Thank you so much for your time. And this is very much a work in progress, and we would value any comments or questions you may have. Thanks a million.
Thank you very much, Mary. Very comprehensive. I'm just going to, as I say, we've essentially opened the webinar, now open to questions. So I have hopefully resolved my technical issues, so I should be able to read them out to you. So maybe Adele and Adele could come back into the picture. So we've got both of you there. We might need both of you to answer some of these questions. So bear with me. Okay, the first one is from Yvonne. Thanks, Yvonne. Sorry. When I say, oh yes, okay, got it now. When you complete the multifactorial falls risk assessment, how do you determine if they are low, medium, or a high risk if there's no scoring available?
That's the whole, the idea is that there is no numerical value will tell you how much a person is at risk. The idea is that you identify the risks and then you deal with those risks. You have interventions to deal with each of those individual risks within your falls care plan. So, for example, if you identify within the medication area that somebody is on antihypertensives and now their blood pressure is low, then you will be consulting with the GP in relation to maybe a review of the medication. If, for example, that you find that the lighting is poor in the room of that person, then you will be carrying out interventions to deal with that and improve the lighting. So it's not about having a score or a numerical value. It's about dealing, identifying all of the risk factors and then implementing interventions based on the risk factors that you have identified.
Thanks, Mary. Again, very comprehensive answer. A question from Julie Bradley now. Maybe a comment more than a question, but it's Julie's saying that the plan of care should also include other meaningful activities which improve physical stamina. Sorry, I'm just having a wee bit of trouble here. I think I've lost you. Sorry, plan of care should also include other meaningful activities which improve physical stamina, standing tolerance and balance, in addition to exercise programs. So it's just a relay comment. Thank you, Julie. And Yvonne McLaughlin has asked us, will these templates be piloted in disability services as well as older persons? Adele, I'll let you field that one.
Yes, yeah, because as part of our group, we had, Mary was from the clinical nurse specialist. We also had the private nursing homes. We had mental health services. So, this is something that's going to be used throughout all services. So yes, it will be, absolutely.
Thanks, Adele. And Caroline Wheeler, hi Caroline. She's said that in disability services we added behaviour as an area to be considered in the MFRAT. And this is separate from cognitive status of the person, as behavioural outbursts may increase the risk of falls for the person and others. So thanks. Caroline, that's something for us to consider, absolutely.
Exactly. Yeah. Thank you. Thanks for that.
And this is something, if
feedback is really good.
Yeah, absolutely.
Mary Gallagher has sent us one in. Is there a shared learning module MDT day that nursing team, OT, physio can all attend together to ensure a consistent approach?
No, but this will be something that we will be developing, okay, after the framework.
Yeah. I suppose what we did say in the introduction, folks, was that the framework will lead hopefully to an implementation plan. So that would very much be part of the implementation plan, Mary. Thank you. That's the last question. Have we any more questions, folks? You can't give them that easy in a ride. Mary was hoping for 52 questions. We'll give it another minute, Mary, just to see if there's any more questions come in. Otherwise, we'll draw a line under it and end the webinar. We have 27 people in the webinar at the minute. So that's a good amount.
Thanks to everybody.
Yeah, and you have our email addresses. So if there's any comments or feedbacks you might be thinking tomorrow or the next day, email us anytime and we will reply to that. But we really appreciate your feedback, so it's great.
And we will have the slides that we can send out today to all people who registered, and we also will have this, as Adele said, this webinar is being recorded, so we will have a recording. In the next few weeks, we'll send out a link to the webinar to everybody who registered as well. And just a thank you there. Okay, folks, there's no other questions, so thank you very much indeed for attending, and we'll just end the webinar there. Last comments from Adele and Mary?
No, I'd say this is a work in progress. You know, we've been working on the MFRAT, but now we're going to be testing it out, and with your help as well, we'll be getting the feedback, and you know, we can make the changes as we see necessary.
Perfect.
Leave it all.
Thank you all, folks.
Thanks a
All right,
million.
thanks very much.
Thanks for your
Bye.
Thanks for your time. Thanks a million.
Colin.
Bye-bye.